Good afternoon, Dr. Anwar. I was waiting for Dr. Lee, but it's clear that he will be quite late today. Anyway, we will start now, and the recording will be available later, so he can catch up what he missed later on. Today, we are going to discuss two important topics in cardiology. The first one is rheumatic fever, and the second one is infective endocarditis. But before we start, because Dr. Anwar is new with us today, I'd like to welcome him. Thank you very much for your trust and confidence, and we hope that we could raise up to your expectations. And I would like to tell you one thing before we start, Dr. Anwar. I think that you have listened to the previous lectures before, and I think that you might notice that the approach for MRCP is quite different from the typical or classical studying approach in the School of Medicine. The approach here in studying MRCP depends basically on a particular mindset that will enable you to interpret and analyze the data given to you in the question at the same time to reach to the correct answer. It's quite different from the regular studying or the classical studying, and it's at the same time, it's a mind game. You have to collect pieces of puzzle all the time to complete the picture. And once you did that, and once you develop this skill, you can reach false diagnosis. There is no magic recipe for that. All that you have to do is you have to listen to the lecture or watch the lecture. And secondly, you have to read the notes slowly. And after that, you have to go to practicing a question. Practicing a question is the most important aspect in order to be able to pass the exam confidently, because while you are practicing a question, you will develop some skills. And this kind of skills that are required to pass the exam fundamentally. So today we are going to start with rheumatic fever. Rheumatic fever Rheumatic fever is a systemic disease. It can affect multiple organs at the same time, and it has a particular characteristic that it has a tendency to recur. The cause of rheumatic fever is a pharyngeal infection with lines filled with group A of beta hemolytic streptococci. And this is the first question that you may encounter in the clinic and in the exam setting, because particularly you will be facing a clinical scenario about a patient presenting with rheumatic fever, and simply you might be asking about what is the cause or what is the underlying etiology or what is the causative organism of rheumatic fever. Group A, beta hemolytic streptococci is the causative agent. And actually, it presents 2 to 4 weeks after upper respiratory tract infection. And this latent period is the period that is required to develop cross-reactivity or or antigenicity towards the valve tissue or various organ tissue. Okay. And I think, Dr. Anwar, that you have some idea about this issue. And the idea is that the protein forming the lens-filled group A beta hemolytic streptococci carries the same antigenic properties of the valve tissue and other organ affected by rheumatic fever. And in this setting, the body, after infection with group A beta hemolytic streptococci, the immune system of the body will develop autoantibody against the beta hemolytic streptococci. But unfortunately, because of the antigenic similarity between beta hemolytic streptococci and various body tissues, the autoantibody will lose its way and will attack the body tissues and body organs in a particular way. Okay, so this would explain why there is a latent period between, or there is an interval between the infection with group A beta hemolytic streptococci and the development of symptoms and signs of rheumatic fever. To diagnose rheumatic fever, you have to have evidence of infection. Major criteria, these are the Johnson criteria and the minor criteria. And you have to remember that all elements are required for diagnosis. I mean, basically, you should have evidence of infection, okay, because this is the lead, okay, towards diagnosing a rheumatic fever. And secondly, you either to have major criteria or minor criteria according to the interpretation of Jones criteria. Okay, but you have to remember that because sometimes some people misunderstand the Jones criteria and depend basically on major criteria and minor criteria alone. This is not correct. You have basically to have evidence of infection, and then you will look for major criteria or minor criteria in order to diagnose Jones criteria. This is an illustration of the Jones criteria. These are the major criteria here. Joints are affected, it's polyarthritis. Heart is affected, so it's carditis. Nerve nodules in the skin, subcutaneous nodules, erythema marginatum, Sydenham's chorea, and we will go through all of these, but I have put this illustration particularly to remind you about the Jones criteria. These are major and minor criteria. First of all, we need to know what is the evidence of group A beta hemolytic streptococci infection. This is either a positive throat culture of the group A beta hemolytic streptococci or a rapid streptococcal antigen test, which is positive, elevated or raised streptococcal antibody titer, which is known as a SO titer of DNase B titer, or we have a recent scarlet fever. Any one of these four is an evidence of group A beta hemolytic streptococci. And in order to proceed for diagnosis of rheumatic fever, basically and fundamentally, you have to have an evidence of group A beta hemolytic streptococci, because without evidence of beta hemolytic streptococci, you cannot build a solid diagnosis or a solid etiology for the presentation of these patients. For the major criteria, it's very important to know, first of all, the elements or the components of the major criteria, and secondly, you have to know the particular characteristic of each of these criteria, because this criteria has a very unique and peculiar mode of presentation. Carditis means there is an affection of either the pericardium, so this is pericarditis, or the myocardium, so it's myocarditis, or the valve tissue, so it's endocarditis. All the heart layers can be affected in patient with rheumatic fever, and we call it pancarditis. Arthritis is very characteristic here in patient with rheumatic fever. It's not just as arthritis, but it has a special criteria. First of all, it's a migratory fleeting polyarthritis. It affects different joints at different times, so it's migratory. It can migrate from one joint to another, and it's polyarthritis. I mean, more than one joint is affected, and usually large joints are affected in patients with rheumatic fever. You have to understand and appreciate this criteria, because with this kind of description, you will be faced by a clinical scenario. And this is a key word here to diagnose rheumatic fever. If you understand this description and appreciate description and absorb this description, it will be easy for you to reach for your diagnosis. The third component of rheumatic fever is the subcutaneous nodules. Subcutaneous nodules here are painless nodules, and they are small and mobile, but they are painless. This is very important criteria here. And the distribution of nodules also is important. This is as these nodules exist basically on the extensor surface of the joints and the spine. So these subcutaneous nodules are small, mobile, and painless nodules existing or distributed over the extensor surface of joints and spine. Erythema marginatum is very important criterion or very important component of the major criteria for diagnosis of rheumatic fever. They are a geographical type of rash. The graphical type of rash with white and raised edges and clear centers. Mainly erythema marginatum is present on the trunk, side, and arms. And here also distribution of this erythema marginatum is essential, because the distribution here is characteristic. A distribution of erythema marginatum here in this kind of patient is characteristic. Again, these are geographical type of rash, and they are mainly distributed over the trunk, size, and arm. Sydenham's chorea, another important criterion here, another important major criterion here for diagnosis of rheumatic fever. Sometimes we call it sandwich dance. Okay, this is a unilateral or bilateral involuntary semi-purposeless movement, sometimes associated with emotional lability. Emotional lability that means that the patient is emotionally unstable. Sometimes he cries, sometimes he laughs, sometimes he says, sometimes he's happy because he's emotionally unstable and has uncharacterized behavior. And as we proceed in the slides of this presentation, I will show you some photos and some illustrations about these enhanced chorea and other abnormalities. The minor criteria include fever, raised ESR or CRB, arthralgia, prolonged BR interval and previous rheumatic fever. I have to remind you here that in the clinical setting, or sorry, in the examination setting, the examiner or the one who is making the questions, he will not tell you that this is a major or a minor criteria. This data will be dispersed in the clinical scenario, and you have to collect the data. As I've told you, you have to collect pieces of the puzzle and collect them together to have a big picture, okay? And you have to be aware about how to use these major and minor criteria together with the evidence of infective endocarditis, of rheumatic fever. Revised Jones criteria entails that there should be an evidence of recent streptococcal infection. And as I have told you, this is a basic and fundamental component of the Johnson criteria. Without evidence of recent streptococcal infection, we cannot establish a diagnosis of rheumatic fever. This is very fundamental and very essential. Any one of the criteria or any one of the elements I have mentioned to you should be present to justify a diagnosis of rheumatic fever. Secondly, you should have two major criteria or one major criteria and two minor criteria. By this way, you can reach for a diagnosis of rheumatic fever. So this is very fundamental slide here. It's very important and establishing the slide because this is the establishment. This is how can you establish a solid diagnosis of rheumatic fever according to the data given to you in the clinical scenario. For the management of rheumatic fever, you need basically bed rest until CRB is normal for 2 weeks. In some examination question banks, you will find you will find a question about this duration. It's very essential to know that there is a bed rest until CRB is normal until CRB is normal, and this is usually for up to 2 weeks. Then we come to the antibiotic therapy. We can use penicillin, benzyl penicillin IV, then we can use penicillin V oral. If the patient is allergic to penicillin, so erythromycin or azithromycin is given for 10 days. This is the basic antibiotics given for the patient with rheumatic fever. As regarding arthritis, first of all, you have to immobilize the joint, then you have to give aspirin for this patient. And aspirin has a particular side effect, particularly in children, because it can lead to salicylate toxicity. Aspirin here in these patients, particularly in patients with arthritis and carditis, in patients with rheumatic fever, is given in a high dose. So it can lead to salicylate toxicity in the form of tinnitus, hyperventilation, and metabolic acidosis. Tinnitus, hyperventilation, and metabolic acidosis. Sometimes the clinical scenario of the clinical or the question in the exam asks particularly about the side effect of salicylate poisoning. So you will find a clinical scenario about patient with rheumatic fever who is being treated with aspirin and he develops one of these complications, tinnitus, hyperventilation, or metabolic acidosis. For carditis, we use aspirin as in arthritis, and we can use prednisolone in the following condition. And you have to be aware and be watch of this scenario here, because in some questions you will find the question is asking particularly about the indication of prednisolone in patient with carditis. Indications include moderate to severe carditis, that is cardiomegaly, congestive heart failure, or third-degree heart block. If you have a clinical scenario of rheumatic fever with the patient presenting with cardiomegaly or congestive heart failure or third-degree heart block, you have to consider prednisolone therapy in this patient in addition to aspirin. For treatment of chorea, we use either haloperidol or diazepam. And you will find also clinical and find also questions in the question banks that you have asking particularly about the treatment of chorea in patients with rheumatic fever. For the prognosis, there is a common saying that we all have learned in the medical school that tells rheumatic fever licks the joints but bites the heart. Rheumatic fever licks the joints but bites the heart. Okay, what this common say means? This says that the affection or the prognosis of rheumatic arthritis in patients with rheumatic fever is very good. Actually, the joints is left without damage. But in cases of the heart, the case is quite different. 60% of carditis develop chronic rheumatic fever or chronic rheumatic heart disease. Particularly, 70% of the valves affected of the valvular affection comes from the mitral valve. And you will find also one question in the question bank that you have asking particularly about the mitral affection here, which is the most commonly affected valve in cases of rheumatic fever or rheumatic carditis. Mitral valve is the most commonly affected valve. Okay, here we come to a very important topic in patients with rheumatic fever, which is the secondary prophylaxis. You will find a lot of clinical scenarios targeting particularly the secondary prophylaxis in patients with rheumatic fever. And as you know, Dr. Anwar, we mean by secondary prophylaxis that this is already a patient who has an attack of rheumatic fever and you want to prevent another attack of rheumatic fever. Here, particularly, you have to know two things and you have to be aware of two things. First of all, what are the drugs used for secondary prophylaxis? And secondly, one the most important thing, what is the duration of secondary prophylaxis? So while you are thinking about secondary prophylaxis in patient with rheumatic fever, you have to consider the drugs used for secondary prophylaxis and the duration. This is very important. And here is a minefield for a lot of questions in the question banks and the examination, okay? Because the duration here is variable according to the incident or according to the pathology or according to the affection or the damage that happened to the heart as a result of rheumatic fever. Basically, we use penicillin V every 12 hours, or we use sulfadiazine daily, or we use erythromycin twice daily if the patient is penicillin allergic. So these are the basic three medications or the basic three antimicrobial agents or antibiotic agents that we use as a secondary prophylactic agents in patients with rheumatic fever. We use either penicillin V each every 12 hours or sulfadiazine daily or erythromycin twice daily if the patient is penicillin allergic. So what about the duration? Duration here is very important because as I told you, it's closely related to the degree of damage or the degree of affection or the impact of rheumatic fever on the heart itself. If the patient has carditis with persistent valvular heart disease, so this patient should receive prophylaxis at least until the age of 40 or lifelong. Okay, so if the patient, this is the first scenario that we'll have, this is the first question that you will have. If the patient has carditis and persistent valvular heart disease, so this antibiotic prophylaxis should continue at least the age of 40 or lifelong. If the patient has carditis without valvular heart disease, you can use this antibiotic agent for secondary prophylaxis for 10 years, a total duration of 10 years. But if the patient developed no carditis at all, you can use for 5 years or until the age of 21. I need this slide to be clear and to be imprinted in your brain, because when you go to find questions and to practice some questions, you will find a lot of scenarios targeting particularly these three clinical scenarios here, because each line here represents a clinical scenario. A patient presenting to you with a rheumatic fever and persistent valvular heart disease, you should give secondary antibiotic prophylaxis for at least until the age of 40 or lifelong. If carditis without valvular heart disease, this is for 10 years. If no carditis at all, you give for 5 years or until the age of 21. This is all about in fact, a rheumatic fever. I hope that it has been clear and clarified now. You will find a lot of questions in the question banks that you have targeting rheumatic fever and particularly asking about the Jones criteria and how can you diagnose rheumatic fever, treatment in acute phase, particularly treatment of arthritis and the treatment of carditis and the prednisolone indication in patients presenting with rheumatic carditis. Secondary prophylaxis, as I've told you, it's a minefield of questions. You have to be aware of the different clinical scenarios regarding secondary prophylaxis in patients with rheumatic fever. Let's move now to the second topic today. This is infective endocarditis. This is infective endocarditis. Infective endocarditis, by definition and by consensus, this is a fever with a new murmur. This means endocarditis until proven otherwise. And I think that you are aware of that, Dr. Anwar, because as I understand that you are a cardiologist. If you have any patient presenting to you with a fever and a new murmur, you have to suspect endocarditis until proven otherwise. And this is a clinical scenario here. You will be encountered as a clinical scenario in the examination, in the question banks that you have, telling you that we have a patient presenting to the hospital with fever for 1 or 2 weeks, and on examination, there is a new murmur, or we will describe a particular murmur, and it will be mentioned in the questions that this murmur is new because it's not present in the patient record. Or the other presentation is that you have a fever with a change on the character or intensity of an initial murmur. And I mean by that, you will have a clinical scenario in the questions that you have telling you that we have a patient presenting with fever, and this patient has a murmur of grade 3 or 4 or 5 or whatever. And basically, by revising the patient record, he has an old murmur of intensity +1. Okay, murmur degree is +1. So if you have a change in the character or intensity of the murmur, and in a patient presenting with fever, you have to consider all the time in the infective endocarditis until proven otherwise. The etiology of infective endocarditis is not a single entity. We have some risk factors, we call it the patient criteria, and we have a particular organisms of particular importance and particular virulence in patient with infective endocarditis. So we need both of them to be present. We need a particular clinical setting or clinical context or clinical scenario in which the organism can culture itself and cause at the end of the day infective endocarditis. You have to be aware of that. The clinical scenario of endocarditis is a classical clinical scenario, but you have to have both elements. You have to have some patient criteria or patient characteristic, and at the same time you have a particular organisms attacking the valves at the same time. So it will, by mixing both together, you can reach to infective endocarditis. Okay, the strongest risk factor for developing infective endocarditis is a previous episode of endocarditis. So basically, if you have a patient with a history of infective endocarditis years ago, presents with you with a fever and the new murmur or a change in the character of an old murmur, this is by definition is infective endocarditis until proved otherwise. And the strongest risk factor here is the presence of a previous history of infective endocarditis. The following are the types of patients that are affected in patient with infective endocarditis. This is very important here. The clinical setting is very important. And Dr. Anwar, you have to absorb this concept, the concept of clinical setting or clinical context. I mean by the clinical setting or the clinical context, the circumstances surrounding the clinical scenario. I need you to deal with the questions as you are reading a novel or watching a movie or watching a show. In the novel or the movie or the show or everything or anything, there is a scenario. You will find elements coming over and over, events and incidents coming over and over, and to establish to the great event, to establish for the great event. This is what is happening in the examination exactly. And this is what I mean by the clinical context or the clinical scenario. You don't have to memorize everything. You don't have to read everything, but you have to absorb this concept in your mind. If by repeating and practicing the question, repeating and practicing the question, repeating and practicing the question, you will develop the skill of identifying the clinical scenario. You will develop the skill of identifying the clinical context. And this is a basic skill in order to answer the correction correctly and pass the exam. In patients with infective endocarditis, there are a particular risk factors, a particular type of patients, or a particular pathology or substrate that should be present in order to develop infective endocarditis. First of all, infective endocarditis can develop in a normal valve. 50% of patients presenting with acute infective endocarditis, they have basically and fundamentally normal valves. The mitral valve is the most commonly affected valve, and you will have some questions in the questions bank asking particularly about this point. What is the most commonly affected valve in patients with infective endocarditis? The most commonly affected valve is mitral valve. What is the most common valve affected in rheumatic carditis? The most common valve affecting is in rheumatic carditis is mitral valve. Secondly, patients with rheumatic valvular heart disease are more liable than other patients to develop infective endocarditis. Third, we have the prosthetic valve. If you have a patient with a prosthetic valve, it means this patient is at risk of development of infective endocarditis. And I think, Dr. Anwar, as a cardiologist, you have faced a lot of patients with prosthetic valves that developed infective endocarditis. Congenital heart disease is another risk factor of infective endocarditis. And here we come to a very important scenario here, the intravenous drug abuser. Typically in patients presenting with infective endocarditis who are basically primarily an intravenous drug abuser, the tricuspid valve is affected here, okay? In contrary to the usual habit of having the mitral valve as the major valve affected in patients with infective endocarditis. And this is a very important clinical scenario. You will find the patient who is intravenous drug abuser presenting with a fever, and you hear a murmur of tricuspid regurgitation, a pansystolic murmur at the left sternal edge that increased with inspiration. And at this point, you have to recognize that you are dealing with a patient with infective endocarditis with a basic affection of the tricuspid valve in the form of tricuspid regurgitation. And this clinical scenario will find a lot of varieties regarding this clinical scenario in the questions that you have with you. Okay, so as regarding the risk factors or as regarding the type of patient, these are the risk factors that you have here. So when you see the question, if you find any of these risk factors, you have to think or to consider infective endocarditis as a possible diagnosis as you see. Okay, let's go now for the organisms. There are particular organisms that have some affinity for the valves, and these organisms are the most important organisms or the most common organisms causing infective endocarditis. All the time, Dr. Anwar, think about infective endocarditis as you have risk factor and you have the right organism. If you have the right risk factors and have the right organism, so you will have infective endocarditis at the end of the day. First of all, the Staphylococcus aureus. It's a very important organism because this is the most common cause of infective endocarditis. Sometimes the question is as simple as is. Sometimes you will find a question about infective endocarditis and you will be asked directly, what is the most common organism of causing infective endocarditis? The correct answer is Staphylococcus aureus, particularly in acute presentation and particularly in patients with intravenous drug abuse. Okay, very important questions that you will see in the question banks. If you start practicing the questions today, you will find this question about infective endocarditis. The most common organism, I have to repeat it over and over because it comes frequently in the exams. The most important organism causing infective endocarditis is Staphylococcus aureus. Second organism here is Streptococcus viridans. Dr. Anwar, maybe a few years before, Streptococcus viridans was the most common organism. It was the historical most common organism of infective endocarditis. But this has changed. This has changed to the Staphylococcus aureus to be the first and the most common organism causing infective endocarditis. Actually, we have two subtypes of the Streptococcus viridans. One is a Streptococcus and the other is a Streptococcus sanguinis. So what is the importance of Streptococcus or what is their significance for us? Streptococcus viridans, including both the Streptococcus mitis or the Streptococcus sanguinis, both of them are present in the oral in the mouth. Both of them are related to dental problems. Both of them can complicate any dental procedure and lead to infective endocarditis. So if you have a clinical scenario in the examination of the question banks that you have telling to you in the information of the question that this patient has a poor dental hygiene or had a dental procedure and then suddenly they develop fever and a new murmur, so this is infective endocarditis due to Streptococcus viridans. In some questions, Streptococcus viridans will not be mentioned to you frankly, but otherwise it will be mentioned the Streptococcus mitis or Streptococcus sanguinis. So you have to be aware of these two subtypes of the family of the Streptococcus viridans. This is very important the clinical scenario, Dr. Anwar, and you have to be aware of the organism here and aware of the clinical setting or the clinical scenario. And this is another illustration of how much the clinical setting is important, because if I have told you that the patient is an intravenous drug abuser and presents with infective endocarditis, you will consider a Staphylococcus aureus. But if I told you that this patient has a poor dental hygiene or following a dental procedure presenting with fever and a new murmur, so you will consider a Streptococcus viridans. This is what I mean by the clinical setting or the clinical scenario. The clinical setting can change your answer and can change your approach, but you have always to recognize the clinical setting or the clinical scenario. The only way is that you will practice, that you can get yourself accustomed to different clinical scenarios is by to get yourself exposed to a lot of questions, to a large amount of questions, because each question has its own idea and has its own concept. Besides that, I have to give you one advice, Dr. Anwar, from a brother and a colleague. Each question bank has its own particular mentality and has its own particular philosophy and has its own particular approach. So in order to be exposed to a lot of ideas, a lot of concepts, a lot of philosophers, a lot of approaches, you have to practice questions from different question banks. So I advise my colleagues all the time, don't depend on one single question bank. Don't depend. Nobody will pass the exam by depending only on one single question bank. You have to get yourself exposed to a lot of ideas, and the only way to get yourself exposed to a lot of ideas is by getting questions from different question banks. I mean, you have to at least to get yourself exposed to two question banks. And my favorite question banks actually is the own examination in past medicine. If this is the first time you study MRCP, go for the past medicine. If this is the second and after that, you have to go for on examination. You have to study both past medicine and on examination. But first, you have to go to the past medicine because past medicine is amateur friendly. Okay, this is just an introduction. It will give you some ideas and it will get you some mind resetting. But the core of the questions and the variability of ideas provided by all examination is outstanding. Myself, I wouldn't have passed first and second MRCP, part one and part two, without getting on examination. I passed them first attempt, both part one and part two by on examination. I got on bus medicine on my side. Actually, I studied it too, but most of the questions, most of the ideas came from on examination. This is not a rule. Okay, sometimes past medicine is good, sometimes an examination is better, but you have to get yourself exposed to a lot of ideas from both. You have to work hard. It's not an easy job, but at the same time, it's not a hard job. If somebody tells you it's easy, he's a liar. If sometimes tell you it's hard, it's a super liar. It's not easy, but at the same time, it's not hard. Okay, so let's continue. There are a particular organism here called coagulase negative staphylococci, just like Staphylococcus epidermidis. And the clinical scenario here is clear. And this is another illustration or another manifestation of the concept of the clinical setting. Commonly, Staphylococcus epidermidis colonizes the indwelling lines. And these are the most common cause of endocarditis in patients following prosthetic valve surgery. Here, you will have a clinical scenario in the questions telling you that we have a patient presenting to you with a fever and a new murmur. And this patient had a prosthetic valve surgery or a valve surgery within 2 months. Within 2 months. If the duration is within 2 months, so the most commonly causative organism is Staphylococcus epidermidis. Be aware of that, please, Dr. Anwar. Be aware of the duration here, because duration here is a key word. And I have also to tell you about the concept of keywords. In each question, there will be one or two keywords that will point directly to the diagnosis. There is no way of knowing these keywords unless you practice a lot of questions. Okay, I will do my best during my course to give people the keywords of each disease. Okay, but at the same time, you have to work hard. You have to work it yourself to develop your own keywords. Okay, so in this clinical scenario, you will have a patient who had a surgery for prosthetic valve repair or replacement, and this patient presents to you within 2 months after the surgery, complaining of fever and the new onset murmur or a change in the previous murmur. So this is infective endocarditis by definition. So what is the most causative organism? The most causative organism in this setting is Staphylococcus epidermidis. Another clinical scenario for here that the patient comes to you after 2 months of surgery, after 2 months of surgery. After 2 months of surgery, the spectrum of the organism which cause endocarditis return back to normal. So Staphylococcus will be the most common organism in this clinical scenario. So our cut-off value here is 2 months. If the patient is presenting to you within 2 months, this is Staphylococcus epidermidis. If the patient presents to you after 2 months of surgery, this is a Staphylococcus aureus. Okay, there is another important organism here, which is Streptococcus bovis. Streptococcus bovis is associated with a colorectal cancer. There is a subtype of Streptococcus bovis called Streptococcus galalicus, and you will find this Streptococcus galalicus in some questions in the question banks that you have. The clinical scenario here either comes in a retrospective or a prospective way. And I mean by that, they will tell you that you have a patient with a colon cancer, and this patient with colon cancer presenting with a fever, and at the same time, new onset murmur or a change in the character of murmur. So this is a case of infective endocarditis. He will ask you particularly about the organism. It's either Streptococcus bovis or Streptococcus galalicus. Or at the same time, he will have another clinical scenario of the same patient presenting to you with fever and a new onset fever or a new onset murmur or a change in the character of murmur. And by doing a blood culture, you will find Streptococcus bovis or Streptococcus galalicticus. The question will be about the screening of colorectal cancer. Okay, so this association either comes in a retrospective or a prospective way. You have to be aware that Streptococcus bovis or Streptococcus galalicticus are closely associated with colon cancer. There are another types of infective endocarditis. We call it non-infective endocarditis. As in cases of systemic lupus erythematosus, we call it Lippmann-Sack endocarditis, or cases of malignancy. These are marantic endocarditis. A very important clinical scenario here that you will find the patient presenting to you with a fever and a new onset murmur or a change in the character of murmur. Echo was done. There is a vegetation on a particular valve, but the blood culture is negative. We call it blood culture endocarditis, blood culture infective endocarditis. You have to be aware of the causes of the blood culture endocarditis. Causes include prior antibiotic therapy, and me, myself, I had one patient last week admitted to our department. His patient had been taking antibiotic for 3 weeks. It's for 3 months, and taking augmentin for not an obvious cause for us, and he doesn't know. He has been advised to take augmentin with no particular duration, and he continued to take this augmentin. He is a patient of prosthetic valve. He has a prosthetic aortic valve, and he presented with us for fever for the last 2 weeks. And we did echo and we find vegetations, but the culture is negative. Culture was negative. Why? Because he had prior antibiotic therapy. This is number one. Number two, in cases of Coxella pernetti or Bartonella or Brucella or the hack organisms. These are the causes of culture negative endocarditis. Sometimes the question will be a direct question. He will ask you one of the following is a cause of culture negative endocarditis, and it will be mentioned one of these organisms in the question, or on the other hand, sometimes it will be a clinical scenario about patient presenting with fever, new onset murmur, or a change in the character of murmur. You did echo, there is vegetation. You did blood culture, blood culture is negative. What is the most probable cause, or the most probable etiology, or the most probable organism, or the most probable bacteria? It will be asking about any of these. Okay, any of these will be in the answers or in the options that you have. Okay, so let's go now to the clinical picture, but I have to remind you all the time, infective endocarditis depends on patient criteria or particular risk factor and particular organisms that should be present on the culture in order to diagnose a patient with infective endocarditis. Clinical features of infective endocarditis are diverse, but they are better grouped under certain titles. First of all, the septic signs. This patient presents basically with fever, rigors, night sweats, malaise, weight loss, anemia, splenomegaly, and the clubbing. This is the constellation of septic or toxic manifestation. Fever, rigors, night sweats, malaise, weight loss, anemia, splenomegaly, and the clubbing. There are cardiac lesions, and we have to be aware of these cardiac lesions. First of all, any new murmur or a change in the pre-existing murmur should raise the suspicion of endocarditis if this patient is presenting with the septic signs. Secondly, vegetations. And vegetations can be diagnosed by echocardiography. And this vegetation can cause subsequent valvular obstruction with subsequent severe regurgitation. And third, you have the aortic root abscess. And this is very important clinical scenario. And you have to remember it all the time, and I will tell you the importance of this clinical scenario as we go through treatment of infective endocarditis. Aortic root abscess can result in prolongation of the PR interval or complete heart block. So if you have a patient presenting with fever, a new onset murmur, or a change in the character of a pre-existing murmur who has a prolongation of the PR interval or a complete heart block, you have to suspect aortic root abscess. What is the importance of this? I will tell you in the treatment, okay? And lastly, patient can present with left ventricular failure. These are the cardiac lesions or the cardiac manifestations of infective endocarditis. Again, immune complex deposition is very important in this kind type of patient because this patient can present with vasculitis that can affect any vessel. We will study vasculitis in the chapter of rheumatology, but for the moment now, any vessel can be affected in patient with infective endocarditis. Secondly, microscopic hematuria up to glomerulonephritis and up to acute renal failure. So this patient with infective endocarditis can present by a microscopic hematuria, glomerulonephritis, and acute renal failure. Rose spots is very important and characteristic finding in patient with infective endocarditis. And Rose spots describe a pouch-shaped retinal hemorrhages. This is very characteristic of infective endocarditis. If you read what spots in any clinical scenario in the questions, this is infective endocarditis. Osler nodules, and we have to stop here for a second to tell you something. Osler nodules and Janeway nodules are very essential and very important. A lot of questions may be simple, may be direct, and may be complicated, targeting these 2 points, the Osler nodes and the Janeway nodes. You have to know the description and the distribution of each of them because a lot of questions in the question banks that you have targeting particularly these points. Osler nodes is a painful bulb infarction in the fingers and the toe. So the first information here is that Osler nodules are painful bulb infarctions, where in the fingers and toes. Bulb infarctions, painful fingers, toes. Bulb infarction, painful finger, toes. You have to remember this all the time. Okay, again, embolic phenomenon. Embolic phenomenon due to septic vegetations that cause microabscesses and distal lesions. And I mean by septic vegetations is the fragment of the vegetations here, the fragmentation of the vegetations here. This defragmentation of the vegetations will travel across the systemic circulation to destination sites, including the brain. And I saw one patient with mycotic aneurysms and multiple cerebral abscesses before as a complication of infective endocarditis. Heart can be affected also, kidney, liver, spleen, lung, and the skin. The skin or cutaneous manifestations of the embolic phenomenon is very important here, very important, because it includes the Janeway nodules. The description of the Janeway nodule is fundamental. The description of the Janeway nodule is fundamental. This is painless, bulbar, or blunter macules. I will show you one illustration explaining both the difference between Osler nodes and the Janeway lesions. Very important. You have to know that Osler nodes are painful, while Janeway lesions are painless. Osler nodes is present in the palm of fingers and the toes, while Janeway lesions are present on the palmar as present as a palmar and the plantar macules. Very confusing, very important. You should never be confused between both of them. You should always be able to identify both of them in the questions. Please, you have to be aware of that. So what is the importance of the Janeway and Osler nodes? Janeway lesions and Osler nodes are pathognomonic of infective endocarditis. This is a clear-cut fact here. Janeway lesions and Osler nodules are pathognomonic for infective endocarditis. Here we go for diagnosis of infective endocarditis. In order to be able to diagnose infective endocarditis, you have to have a particular criteria. It's called Dukes criteria. Dukes criteria. Dukes criteria, you will find some questions in past tests, particularly targeting this Dukes criteria. Okay, infective endocarditis is diagnosed if you have a pathological criteria positive, or 2 major criteria, or 1 major with 3 minor criteria, or 5 minor criteria. 1 pathological criteria positive, or 2 major criteria, or 1 major with 3 minor, or 5 minor criteria here. So what about the pathological criteria? Pathological criteria describes a positive histology or microbiology of a pathological material obtained at autopsy or cardiac surgery from a valve or vegetation or embolic fragment of or endocardiac abscess. Okay, so this is a direct visualization of the vegetations and the causative organism. This is the pathological criteria. So what about the major criteria? Major criteria, you should have positive blood cultures and positive molecular assay for specific gene targets. Positive blood cultures includes, this is very important here, two positive blood cultures showing the typical organism consistent with infective endocarditis, such as the streptococcus or staphylococcus or the other organisms that we have discussed. So we have two positive cultures out of three showing the typical organisms consistent with infective endocarditis, or you have a resistant bacteria from two cultures taken 12 hours apart, or three or more positive blood cultures where the pathogen is less specific, And again, you have positive serology for Coxella burnotii or Bartonella species or Chlamydia pistachii, or you have a positive molecular assay for a gene for a specific gene targets. These are the major criteria. The cornerstone of this major criteria is a positive blood culture. Okay. Secondly, the evidence of endocardial involvement. Evidence of endocardial involvement either by a new valvular regurgitation or positive echocardiography showing the vegetations or the abnormality on the valve. You have to know that in doing investigation for patient with infective endocarditis, he should have a blood culture. Oh, sorry, before that, we have to do the minor criteria. Minor criteria includes predisposing heart condition, as I told you, the clinical setting or the clinical context that we have discussed before, or intravenous drug abuse. Microbiological evidence does not meet the major criteria, I mean other organisms not known to cause endocarditis, fever more than 38 degrees, vascular phenomena or immunological phenomena. Vascular phenomena, we mean major imply splenomegaly, clubbing, the splinter hemorrhages, the Janeway lesions or petechiae or purpura, and by immunological phenomenon, we mean glomerulonephritis, osseous nodes, and the Rosas spots. For taking blood culture, you have to know this piece of information that you have to take three sets of at different times from three different locations or three different sites. The ESR and CRP will be positive in this patient. Urine may show evidence of microscopic hematuria. Chest X-ray can show cardiomegaly on patient with infective endocarditis due to heart failure. ECG will show prolonged PR. This is very important here because prolonged PR should be interpreted into aortic root abscess. And I told you, I will tell you what is the importance of recognizing that there is a clinical suspicion here of this patient of having aortic root abscess as we reach at the treatment section of infective endocarditis. Echocardiography, including the standard echo, transthoracic echo, or that runs esophageal echo that it will show vegetations or aortic root abscess. So what about the treatment of infective endocarditis? First of all, Dr. Anwar, there are two aspects that should be kept in the mind here while we are starting the treatment of patients with infective endocarditis. First of all, you have to ask yourself, is this a native valve? Is this a native valve or is this a prosthetic valve? Secondly, what is the suspected organism in this patient? Native valve and prosthetic valve, it will be appreciated from history. And the most important thing is what is the most causative organism or what is the suspected organism here. And it's also can be interpreted and can be extracted from the history of the patient as we have discussed in different clinical scenarios regarding the most common organisms affecting the valves and causing infective endocarditis as we have mentioned before. First of all, you have to know what is the initial blind therapy. If we have a native valve, here, so our initial therapy will be amoxicillin, and we would consider a low dose of gentamicin. Amoxicillin with low dose of gentamicin. If the patient is penicillin allergic or MRSA or have severe sepsis, we can use vancomycin and low dose gentamicin. But if we have a prosthetic valve, we give vancomycin from the start with rifampicin, and we keep the low dose gentamicin. This is very important here, Dr. Anwar. If you have an initial blind therapy, use native and affecting a native valve. If the infective endocarditis affecting a native valve, use amoxicillin with low dose gentamicin. If the patient is penicillin allergic or MRSA is suspected, or patient has a severe sepsis, you use vancomycin instead of amoxicillin, and you keep low dose gentamicin. If the patient has a prosthetic valve, you should start from the beginning with vancomycin, rifampicin, and low dose gentamicin. Okay. If you have a native valve, that valve endocarditis caused by The antibiotic of choice here is flucloxacillin. But if you have this patient is allergic to flucloxacillin, you will use vancomycin with rifampicin. Okay, vancomycin with rifampicin instead of the flucloxacillin. Again, if you have a prosthetic valve endocarditis caused by a staphylococci, so remember, Dr. Anwar, this is a native valve here, while here it's a prosthetic valve. I told you when we started treatment of infective endocarditis, I told you the treatment of infective endocarditis will depend on the valve. Is it a native or a prosthetic valve? And at the same time, it will depend on the causative organism. So for patient with prosthetic valve endocarditis caused by staphylococci, we use flucloxacillin with rifampicin and low dose gentamicin. If the patient is allergic to flucloxacillin, we use vancomycin, rifampicin, and low dose gentamicin. This is the same regimen that have been used as the initial blind therapy in prosthetic valve. Again, if you have a patient with endocarditis caused by fully sensitive streptococci, we mean by this streptococcal viridans that complicates dental procedures or complicates the situation in which patient has a poor dental hygiene, we give benzyl penicillin. Benzyl penicillin. If the patient is allergic to benzyl penicillin, so we give vancomycin with low dose gentamicin. If this endocarditis caused by less sensitive streptococci, you will use benzyl penicillin with low dose gentamicin. If again the patient is allergic to benzyl penicillin, you will use vancomycin and low dose gentamicin. This is the antibiotic therapy for patient with infective endocarditis. So what about the indications of surgery? Very essential and very important question here. What are the indications of surgery? You have 9 indications for surgery in patient with infective endocarditis. The first one is heart failure. So if you have a patient presenting with a fever, a new murmur, or a change in the character or intensity of an existing murmur, and this patient is presenting with heart failure, it's done. This patient is for surgery. And 1 month back, I had one patient present to us with acute aortic regurgitation due to infective endocarditis. It was complicated by heart failure, and we referred him to immediate surgery. Under cover of antibiotics, this patient had an aortic valve replacement. He is alive and doing well now. Secondly, valvular obstruction. If this patient presents with valvular obstruction, this is an indication of surgery. Third, repeated embolization, repeated severe stroke, repeated mycotic aneurysms, repeated glomerulonephritis. Any repetition in embolic manifestation is an indication of surgery in this patient, because now this valve is a septic focus that spreads vegetation all over the body and and causing embolic manifestation. Okay, fungal endocarditis, it by itself is indication for surgery because antifungals will not work in this kind of patients. Persistent bacteremia in spite of antibiotic therapy, a very important clinical scenario as an indication for surgery in patients with infective endocarditis. Myocardial abscesses, another important one, unstable infective prosthetic valve, okay, and severe aortic regurgitation. I told you now that we had this patient with severe aortic regurgitation, acute aortic regurgitation due to infective endocarditis, and we referred him complicated by heart failure, and we referred him directly for surgery. Aortic root abscess is an indication of surgery. How can you recognize aortic root abscess? Patient with fever, new onset murmur, or a change in the character of existing murmur on ECG. There is a prolonged PR interval or complete heart block. I suspect aortic abscess. This is an indication for surgery. No antibiotic can correct this clinical situation. There are some poor prognostic factors here in patients with infective endocarditis. These prognostic factors include Staphylococcus aureus infection, and you will have a couple of questions here in the question banks that you have, targeting particularly the poor prognostic factors in patients with infective endocarditis. Staphylococcus aureus infection, prosthetic valve, especially if it's early, within 2 months of surgery, early infective endocarditis affecting prosthetic valve is a poor prognostic factor in patients with infective endocarditis. Culture negative endocarditis, because no antibiotic will work on these particular organisms in these particular situations. And low complement level. Low complement level means that the complements have complements have been consumed, and there is a heavy toll of infection and a heavy toll of immune complex deposition in the body. Okay, so you have to know that this is one of the poor prognostic factors in patients with infective endocarditis. Mortality can depend basically on the organisms. In Staphylococcus, the mortality is 30%, in Streptococci it's 5%, and in cases of bowel organisms it's just 15%. Okay, this was about the treatment in patients with infective endocarditis. Let's move now to another important section in infective endocarditis, that is the prophylaxis of infective endocarditis. As far as you can remember, Dr. Anwar, before, while we studied in the medical school, antibiotic prophylaxis was recommended as a routine in patients with infective endocarditis. But this is not the case now, because in 2008, guidelines from the National Institute of Clinical Excellence, they have radically changed the paradigm here, and they changed the list of the procedure for which antibiotic prophylaxis is not recommended. Routinely, antibiotic prophylaxis is not routinely required for the following procedure. Any dental procedure, there is no antibiotic prophylaxis required. The upper or lower GIT tract or GI procedures, genitourinary procedures, or upper and lower respiratory tract procedure. If any of these procedures, there is no routine antibiotic treatment. No routine antibiotic treatment is required as a prophylaxis against infective endocarditis. You have to be aware of that. But remember, Dr. Anwar, for every rule, there are some exceptions. For every rule, they have some exceptions. We have two exceptions here for this rule. Number one, any episode of infection in patient at risk of infective endocarditis should be investigated and treated promptly to reduce the risk of infective endocarditis. And this sounds logical. Any episode of infection in patient at risk of infective endocarditis should be investigated and treated promptly to reduce the risk of endocarditis. But let's move now to the important exception here, because this is very important and deceiving and confusing exception here. Because in the clinical setting, you might be confused easily if you don't know this piece of information in the paragraph here. Listen to me, Dr. Anwar. If a person at risk of infective endocarditis is receiving antimicrobial therapy because they are undergoing a gastrointestinal or a gastrourinary or a genitourinary procedure at a site where there is a suspected infection. Listen to me. If you have a patient presenting to you who is at risk of infective endocarditis, and at the same time, this patient will do a procedure, either a genitourinary or a dental procedure or a gastrointestinal procedure. But it happens that at the site of the procedure, there is an infection. I mean, if we do going to do a genitourinary or a scope of the vagina, and this patient has vaginal infection, or if you have to do a scope of the urethra or a cystoscope of the urinary bladder, and the patient has UTI, or the patient is going to do endoscopy, and at the same time he has infection in the rectum, okay? Or the patient is going to have a dental procedure, and at the same time he has infection in his teeth, okay? This is the exception here, because this is an indication of antibiotic prophylaxis. I mean, if a person at risk of infective endocarditis is receiving antimicrobial therapy because they are undergoing a gastrointestinal or a genitourinary procedure at a site where there is a suspected infection, they should be given an antibiotic that covers organisms that cause infective endocarditis. Is this clear, Dr. Anwar, for you? You can write on the chat box or you can unmute. I will unmute you in order to communicate with me. Is this particular point is clear, Dr. Anwar?
Yes, sure.
Is very important exception. Sometimes this question is deceiving, is evil in the exam, because we depend on our basic knowledge that routinely antibiotic prophylaxis is not required in the procedures that we've mentioned in patient at risk of infective endocarditis. But this is a particular exception here. So when you read the question about prophylaxis of infective endocarditis, be careful about this exception. Okay. Right. Let's move to this is here. This is here. Can you see? This is the Osler notes, as I've told you, a painful notes in the palm, fingers, and toes. Okay, this is the Jan way. These are the painless macules in the palms and soles. These are splinter hemorrhages, and these are the rose spots, boat-shaped hemorrhages in the retina. And this is are again Osler nodes, and again these are painful nodes at the palm of fingers and toes. Okay, this patient has Sydenham's chorea. Sydenham's chorea. You can see here patient is doing semi-purposeless movement, okay, and has some emotional ability, dancing. So we call it a sandwich dance. And this is sandwich, okay. And again, then you can see here Sydenham's chorea, okay. Now, Dr. Anwar, I would like to stop here today, okay, because I know that you have about 3 lectures beyond us, right?
Yes.
Okay, now we finished our first section in cardiology. We finished infective and we finished the valvular heart disease, diseases of myocardium, and the diseases of the pericardium. So in the next lecture, I need you to revise all the previous lecture and to revise today's lecture also, to start solving some questions about valvular heart disease and infective endocarditis. Our next lecture will be about ischemic heart disease. It will be a long lecture, and actually this is a different mindset away from the valvular heart disease. So I will stop here only for the sake of establishing what we have studied previously, because at the beginning of our next lecture, we will make a review by questions about valvular heart disease, infective endocarditis, pericardium, myocardium, and the fundamental basics. So we make sure that what have been studied is being absorbed correctly, and then afterwards we will proceed into the more complicated issues as ischemic heart disease. Okay?
All right.
Okay, do you have any questions now, Dr. Anwar, either about the lecture or about the course structure or anything?
You elaborated very well.
Okay, thank you very much. I need you today. I will send now the recording already that you have the PDF, I think. I will send now the recording after being uploaded to the Google Drive. It will work after 1 or 2 hours because the Google processes the videos. It takes 1 or 2 hours in order to be available for watching. After that, I need you to listen to the lecture again or to read the notes and start hunting for questions. Start hunting for questions. Okay, starting hunting for questions about myocardium, pericardium, valvular heart disease, infective endocarditis, and rheumatic fever. You will find all the clinical scenarios that we've mentioned here present in questions, and this will help you to memorize well and to develop a skill of mind resetting and reasonable clinical thinking with interpretation and analysis of data. And this is all that is required for the MRCP. And as I've told you, Dr. Anwar, there is no easy way, there is no hard way. If somebody tells you it's easy, he's a liar. If somebody tells you it's hard, he is a super liar. Okay, but you have to work hard to pass the exam. But the most essential part is by solving a lot of questions. My role is guidance. My role is mentorship. I will guide you through this course until the exam day. Okay, and I'll guide you to the hot topics. I'll guide you the keywords, how the question is presenting. I will give you a plan. I will revise question with you. We will make assessment. We will do a lot of activities together. So we'll enjoy studying the MRCP and hopefully you will pass the exam. Do you have any question or anything?
Yeah, thank you very much.
Thank you very much. I'll see you next Tuesday at the same time. We will study ischemic heart disease. It will be a very important lecture. Okay?
Yeah, okay. Thank you.
Okay, thank you. Good luck. Thank you. See you.